Good afternoon and welcome to the 35th North American Cystic Fibrosis Conference. Each year at NACFC, we have the privilege of coming together to learn from one another and to celebrate the outstanding progress of the global CF community. You make that progress possible, even in the most challenging of times. You partner with people with CF and their families, you carry out vital research in the labs, and you devote your talents to raise precious funds and awareness for our shared mission, a cure for every single person with CF. Thank you for joining us today and for your hard work and dedication. You are transforming lives and this disease. I send a special welcome to those of you who are living with CF. Your strength and courage to show us that together we can achieve goals that we never thought possible. For the second year, we come together virtually and more determined than ever to help people with CF live long, healthy, and fulfilled lives. Many amazing things happen at NACFC, but most meaningful to me are the connections that we make. Every new connection strengthens each of us and our collective commitment. I hope that over the next 2 days, you will find new ways to connect, collaborate, and innovate together. Now it's my honor to introduce the President and CEO of the Cystic Fibrosis Foundation, Dr. Michael Boyle. It's been an extraordinary time, and we are so fortunate to have an exceptional leader that is pushing forward on vital research, improving CF care, and keeping us closely together as a community. Mike, we thank you for this and for your exceptional leadership.
Thank you, Cam. And greetings, everyone, and welcome to the 35th Annual North American Cystic Fibrosis Conference. Thank you for joining us. It is great to be together, to once again learn from each other, inspire each other, and be energized to take on our shared mission to serve people with CF, develop new therapies, and eventually cure this disease. As we open our meeting, I want us to take a few minutes to do two things. First, reflect on what together we have accomplished in CF over these last 2 years. And second, to pull back the curtain and allow us to get a brief glimpse of what lies ahead. In both of these areas, you will see a common theme that no matter what the circumstances, no matter what the challenges, the CF science and care community, in partnership with people with CF and their families, continues to make remarkable progress and advance the amazing CF story. Let's start by taking a moment to reflect on what we've accomplished together. While we certainly have work ahead, we have so much to be grateful for regarding how the CF community has pulled together to navigate the COVID pandemic. I'm sure each of us can all recall our initial thoughts when COVID-19 first began, that this could be an absolute disaster for people with CF, a severe respiratory virus targeting those with severe respiratory disease. But let's look at what has actually happened. The numbers of those with CF made seriously ill by COVID has thankfully been much less than we feared. In fact, consistently over the pandemic, only 15% of people with CF infected by COVID have required hospitalization. We've had robust international cooperation among the CF community on a global data reporting project to track and better understand the experience of people with CF and COVID. Care teams have worked closely with those with CF to ensure that they could receive top quality CF care, whether through telehealth or increasingly now through in-person visits. And the availability of vaccination is starting to help us all feel more confident about the future. So thank you for your work and commitment. Because of you, successfully maneuvering through COVID has become just one more example of what the entire CF community can accomplish when we pull together to take on a challenge. Now that in and of itself is good news, but even more amazingly, over the course of the pandemic, we have not just held, but have actually gained significant ground clinically. Part of this story certainly has been the increasing availability of Trikafta worldwide, its expansion to ages 6 to 11 in the US earlier this year, and the growing understanding of the dramatic impact that a highly effective CFTR modulator can have on the lives of people with CF. I want to briefly share some data with you that highlight just how much clinical ground we have gained even while maneuvering through a pandemic. For starters, this past year, only 17% of adults with CF in the US required treatment with IV antibiotics for pulmonary exacerbation. This is dramatically down from the 40% where it had been every year for the last decade. This past year, the number of pregnancies in women with CF in the US more than tripled. Every year for the last decade or so, there have been about 200 pregnancies in women with CF in the US. This past year, there were 619. Lastly, I feel obliged to mention a landmark survival statistic. As you know, we calculate median predicted survival in 5-year averages in the CF patient registry because it can vary from year to year. But in the most recent 5-year block, from 2016 to 2020, median predicted survival reached 50 years of age for the first time, a reason to celebrate. And I think we are all confident that it's only going to get better from here. So there is clearly much to be thankful for in the care area. But what about in the cure area? Have we been able to continue to press forward our shared work to develop new therapies and advance towards a cure during a pandemic? To answer that, let's take a look at our progress on the path to a cure, the CFF initiative to assure that we develop therapies and eventually a cure for all people with CF, no matter what their mutations. Since the initiative was rolled out just before COVID hit, we have added 24 major research programs focusing on the path to a cure, which cover a wide range of research in new genetic technologies, including mRNA therapies, nonsense mutation therapies, gene therapy, and gene editing. And in addition to continuing to invest in innovative research, we've also been pursuing new innovative strategies to bring the best science from around the world into CF. One of these innovative approaches has been to collaborate with biotech venture capital firms that have earliest access to cutting-edge science and make sure that they apply it to cystic fibrosis. Last August, we announced a $30 million collaboration with the Longwood Fund to accelerate genetic therapies for cystic fibrosis, and that has already resulted in the development of 3 new companies focused on path to a cure technologies. More recently, we announced a similar collaboration with Flagship Pioneering, the top-performing biotech venture capital firm of the last decade, to apply their most promising technologies, including gene therapy and gene editing, to cystic fibrosis. You'll hear more about this in tomorrow's plenary. These are just 2 examples of our absolute commitment to ensuring the development of transformative therapies for all people with CF, no matter what their mutations, and eventually a true cure. Of course, while advancing the therapies of tomorrow, we are simultaneously working to address the complications of today. Just a few examples of this include multiple clinical trials underway to explore the use of phage therapy to help address difficult to treat infections, continued development of next-generation synthetic pancreatic enzymes to optimize nutrition and GI health, an expansion of the CF Foundation's Lung Transplant Consortium dedicated to improving long-term transplant outcomes. So together, we have absolutely been able to continue to advance CF research despite COVID. Thank you for making this possible. Now, what can we expect in the years ahead? As we plan for the future, we continue to focus on what we call the 3 C's: cure, care, and community. And I'm going to add a 4th C, continued progress. In cure, we're going to see the first wave of genetic technologies starting into clinical trials, providing hope for all of those who are unable to benefit from CFTR modulators and ushering in the next era of CF therapeutic development. In care, we will gain increasing understanding of the full benefits of highly effective modulators, especially the impact of treatment at earlier and earlier ages to alter the course of the disease. In community, we're going to see the continued rise of adults with CF playing a central role as partners in optimizing care and advancing our work to defeat this disease, including many who previously had not felt connected or felt included in these efforts. So as we look ahead, let's stay focused and determined. There are big things ahead in every area of CF, and together we will continue to write the amazing CF story of progress. We're now going to move into our first plenary. While we typically focus on basic science in the first plenary, this year we thought it essential to recognize the incredible dedication of our care teams in navigating the COVID pandemic, and therefore have moved the clinical care topic to the first plenary. In just a few minutes, we'll hear from Dr. Michelle Prickett, who will reflect on the CF community's experiences throughout the pandemic, identify lessons learned, and outline how we can draw on those lessons to forge the path forward to optimize CF care. Tomorrow, for the second plenary, we'll focus on basic science, and you'll hear from Drs. Martin Mentz, Hilary Valerie, and Jed Mahoney on advances in the CFF lab, which are helping to push forward path to a cure discovery and development. That session will be introduced by Dr. Bill Skatch, who has graciously continued to serve as the CF Foundation's Chief Scientific Officer as we work to identify our next CF Foundation CSO. And then on Friday, Dr. Manu Jain will lead the third plenary, highlighting recent data on the real-world impact of highly effective modulators, as well as provide an overview of other emerging clinical research data. It's now my pleasure to introduce Dr. Bruce Marshall, the Executive Vice President and Chief Medical Officer at the Cystic Fibrosis Foundation, who will introduce our first plenary speaker. Thank you once again for all you do for people with CF, and enjoy the plenary.
Thank you, Mike. I have the pleasure of introducing today's speaker. Dr. Michelle Prickett is an associate professor of medicine at Northwestern University. She has served as associate director of the adult CF program for over 10 years, as well as medical director of respiratory care at the 900-bed Northwestern Memorial Hospital. She was the recipient of a CF Foundation Fellowship Training Grant and a PACE awardee. She has also participated and been a key contributor to several CF Foundation-sponsored programs, including the Success with Therapies Research Consortium, the CF Learning Network, and the Partnership Enhancement Program. Born and raised in working-class Chicago, the younger Michelle was a sports fanatic. She attended the University of Illinois on an academic and later an athletic scholarship as a member of the NCAA Division I women's volleyball team. After completing a Master of Science in Exercise Physiology, she entered medical school with the goal of becoming an orthopedic surgeon. Fortunately for us, she found the lungs are much more interesting than bones and joints. As an internal medicine resident at Northwestern, she was mentored by Dr. Manu Jain, director of the adult CF program. The opportunity to attend CF clinic and meet an amazing group of young adults with CF sealed her decision to pursue a pulmonary and critical care fellowship. And as they say, the rest is history. One final note for those sports fans with ties to Chicago, Michelle is a diehard Cubs fan. She really enjoys watching games at Wrigley Field with her husband and their 3 young sons. Now, before I turn it over to Michelle, here's a look back at what we've experienced over the past year.
It is no doubt that COVID-19 has had a significant impact on mental, physical, and the entire well-being of everyone.
Hi team. I know how stressful this time is for everyone, but especially for you guys. And I just want to say thank you so much for helping all these people and for staying strong. I miss you all.
You guys are certainly at the front lines of this thing. We know how amazing you all are at what you do.
We've all been cheering for you from our homes.
We appreciate you guys, all that you do and have done.
We wish you nothing but health through all of this and just well-being, and that your families are okay.
I wanted to let you know that I'm thinking about you underneath all this gear.
We really miss seeing you in person in clinic.
We're still here for you.
We've utilized telehealth a lot this last year, and that actually has been kind of an amazing thing.
I may see the inside of a patient's house. I may meet their dog.
As a technologically challenged person, I've needed to bravely go where I've not gone before. I look forward to an encounter with you by phone or maybe video.
I'm thinking of all of you and looking forward to seeing you guys back in clinic real soon.
For patients out there, we miss you. Healthcare providers out there, we miss you. For colleagues out there, we miss you.
Stay home, stay safe, and we're here for you.
I hope everybody is staying safe and healthy, and we look forward to seeing you guys back in clinic real soon.
So, wow, that video had so many familiar faces and so much positivity. It's so hard to follow. But thank you, Bruce, for that wonderful introduction. And I am so pleased, honored, and really awestruck to be speaking with you today about the lessons learned from a very difficult time in many of our lives. I would like to share some of my own experiences as an example of the challenges many of us have lived through and honestly are continuing to live through to this day. There have been many hard times over the past year, but also resilience and hope, just as we saw in that video. I will reflect on our experiences as a community and identify lessons learned as we continue to navigate uncertainties in this changing world together. So with that said, my pertinent relationships regarding this talk are related to funding support through the Cystic Fibrosis Foundation. And most importantly, through the invaluable relationships through the CF community that I've developed over the years that have influenced the thoughts that I will be sharing with you today. So where are we headed during our time together today? I will summarize the impact of the COVID-19 global pandemic and really as the catalyst to shape how we are providing CF care. I will also offer my thoughts on the key drivers that evolve CF care in this landscape, as well as identify future CF care needs in the setting of highly effective modulators and telehealth care delivery. All right, before we look forward, it's important that we look back and put into context all that has happened over the past 2 years. Let's start with October of 2019, when we were together last at NACFC celebrating the FDA approval of Trikafta. This event featured a fantastic plenary by Professor Jane Davies, finished off by a rousing sing-along of Dare to Dream, led by the legendary Dr. Francis Collins. It was a real high point in a time of celebration and joy. And before we go on, just to be clear, I will not be singing for you today. You are welcome. However, shortly after that milestone, we started to hear about the development of a novel coronavirus that was emerging halfway across the world. And only 1 month later, we found our first outbreak of COVID-19 here in the United States, affecting our colleagues in Seattle and the Pacific Northwest. Pretty soon thereafter, in March of 2020, we started to see huge outbreaks of COVID-19, especially in some of our large cities, including my hometown of Chicago. This led to more widespread outbreaks across North America and the world, resulting in the first ever virtual NACFC in October of 2020. And then science again offered a chance for celebration, with the FDA approving highly effective and safe vaccines, finally providing a light at the end of what has been a very long and dark tunnel. However, here we are in November of 2021 at another NACFC that was initially hoped to be in person. However, given the new variants and rapid spread of cases, this event was also transitioned to being virtual, with all of us sitting behind screens, which admittedly is just not the same. This brings us to present day and making the most of the opportunities before us as we face the future of CF care with new challenges, changes, and progress yet to come. Throughout the pandemic, everyone has had a story, and I am just here to tell you mine. As you can see, this is a picture of me in 2019. I was youthful and chipper and had very well-coiffed hair in the pre-pandemic world. At that point, I was also many things to many people. I was the daughter of a toolmaker and stay-at-home mom growing up in working-class Chicago. I was also an athlete. Sports were in my blood at a very early age. And eventually I became an NCAA college volleyball player. I later became a wife, and afterwards a mother of 3 boys, ages 6, 8, and 10 at the start of the pandemic. I was also an academic clinician educator, so I spent a lot of my time teaching in the clinical setting, including the clinic, ICU, and inpatient pulmonary services. And for the last 10 years, I've been medical director of respiratory care for Northwestern Memorial Hospital, which is a 900-bed university-based hospital in downtown Chicago. And like most adult pulmonologists, I'm also a critical care trained ICU intensivist. And as many of you know me, I'm also a CF doctor. So that was me pre-COVID. And this is me in the COVID era. As you can see, a lot has changed. And I'm going to lead you through the story of how my life was upended and altered, and some of the things that I experienced during this journey. My COVID-19 experience started with me being in the ICU service in early March of 2020. We had heard about potential of a new virus leading to respiratory failure, but we had yet to see any in our community. No cases had been identified, but I was very concerned and took the unusual steps of self-quarantining that week at start of service just to make sure I protected my family. And I was glad I did, because while we started with 0 COVID-19 cases at the start of the week, we had 7 by the end of my week, with patients coming in fast and furious, and we were experiencing something that was a previously unknown disease course. There was a lot of fear and a lot of unknowns. Also, schools closed, so I set up remote monitoring or remote learning for my boys while I remained at what my husband quoted the quote-unquote mom cave. And I also turned over outpatient care to my CF team so I could focus on respiratory therapy needs, which were new. These included 5:30 a.m. meetings, followed by multiple emails, chats, meetings throughout the day, really to help us understand how we can build that support for my hospital and for my teams. I also switched to the night shift, which just to meet our increasing staffing needs. And while pulling all-nighters was really fun during my college years, let me tell you that this 40-something who's usually in bed by 9 o'clock did not find it to be so enjoyable. So as you can see, there is a big visible change, but it's important to note how vastly care delivery changed as well. And to recognize and contrast what we were seeing in COVID-19 care and comparing it to typical CF care. So in CF care, we have long-standing data resources. We know a lot about our patients, and everything that we do is really guideline-based care. I also had a very close seasoned team that worked well together for many years. We provided longitudinal care with a goal to help our patients live long and healthy lives. And with that, our patients were typically well known to us, having formed close relationships over years to decades of face-to-face encounters. Now, how does that compare to COVID ICU care? Well, in the COVID ICU, we started with very minimal data at the onset. There were no pre-existing guidelines, and we were working with each other and collaborating frequently to help determine best care. And we had large teams to meet the demands of our patients, and with very diverse skill sets. We were providing high-level critical care for patients that were not known to us, and most importantly, we typically couldn't speak to due to illness. So most of our discussions were through family surrogates, and these individuals were also only accessible to us by virtual contact. So how we delivered care was very different from what most of us had experienced, and we needed to learn and grow, and we needed to do it quickly. So at the outset, I asked myself, what skills do I have to deal with this global pandemic? I didn't feel prepared, and like Napoleon Dynamite, I questioned what skills I had to offer. I was clearly not a public health expert, and while I had knowledge in viral pneumonias, COVID-19 was nothing like I had really seen before. But I did have skills. And thinking about it, I had a strong foundation of research and critical thinking skills. I also had a background in quality improvement and embraced small tests of change. I had training in communication. In addition, leading teams was something very familiar to me growing up as an athlete. And if none of that worked, I had empathy and the ability to listen and to console people. And finally, I was humble. At the outset, I would remind myself there are no COVID-19 experts. No one's been doing this for 20 years. No one's seen COVID pneumonia, which admittedly was not like anything I had seen in my career to that point. So having an open mind in terms of addressing and embracing change was a skill that would serve me well in the months and years to come. So what does this look like in the ICU? Yeah, well, in the ICU, it looked like full PPE for all patient encounters. So here you'll see a picture of me with masked goggles, gowns, face shields, gloves, and I was accessorized with a very dashing blue bonnet. And let me reassure you that it was as comfortable as it was stylish. Our ICU teams have always seen a large number of patients, but this ballooned to 3 times its normal level in just a few short weeks. We were able to accommodate this by canceling all elective procedures and expanding to not only every bed in our ICU, but also converting many of our alternate care areas to facilitate non-COVID care. Patient rooms were developed at any place we could find a bed, including post-op recovery units and procedural bays. It was unprecedented times indeed. And with all those patients, we really needed to reimagine our workforce. We couldn't do the same 3 times the amount of work with the same number of staff. So we incorporated our traditionally non-ICU medical physicians who volunteered to come to the ICU and help, but we had to find a new way to integrate them. So what you'll see here is a picture of me working with one of my teams, and it includes a cardiology fellow, a gastroenterologist, an endocrinologist, a trauma surgeon, CRNAs, and some of our advanced practice providers in the ICU. It was truly the United Nations of care teams, and everyone had a skill to offer. We also initiated dedicated communicators for families, and these consisted of outpatient clinicians who would attend ICU rounds with us and then call families every day to convey the plans and address any concerns. Communication was a procedure, and it was handled as such, just like those placing central lines, airway teams, and other volunteers. Each member had a role, and together we were able to provide quality care by building on our own skills and talents. As medical director of respiratory care, I admit I am biased, but respiratory therapists have been the unsung heroes of this pandemic, holding very heavy loads throughout the last 18 months to 2 years. They were at the front lines and honestly the head of the beds, helping to address questions about ideal vent and oxygen usage while working with whatever equipment we could get our hands on. Here are some of our awesome respiratory therapists at Northwestern Memorial Hospital. We also partnered with Larry Children's Hospital, which is across the street from us, and they generously lent us some of their ventilators for use in our adult patients. As you can see here, they came prepackaged with "I'm ready to save grown-ups," because what else would you expect from our amazing pediatric counterparts? We also worked with researchers and developed and implemented remote access for ventilators. And within a few short weeks, we were able to create new ways to both monitor and adjust our ventilators without going inside the rooms. And this really helped to minimize staff exposures in a time when it was so critically important. What about the clinic? So our CF clinic, like many of yours, converted in the early days to completely telehealth. Our MDs were essentially reassigned to ICU services. And unlike many institutions across the country, we were fortunate and none of our staff was furloughed. However, time off was significantly restricted. As our physicians were primarily deployed to the ICU, our CF team restructured our outpatient care. Outpatient needs were primarily filled by our APN, our nurses, respiratory therapists, dietitians, pharmacists, social worker, and our research coordinators who held that shift steady, just like the seasoned pros that they are. As you can see here, we would meet virtually once a week to go over patients, answer questions, and really just check in with each other and make sure everyone was okay. So that was work, but what about home? So my home life centered around my husband and my 3 boys, where we managed remote-only school and work from home for over a year. And as you can imagine, with a home full of boys, this led to many tears and close quarters. We had no sports, we had no play dates, and the bright spot was our family evening walks at scooter rides with our dog Addison to nearby Wrigley Field. So this was my story, and hopefully it gave you some insights into what some of your colleagues may have experienced, or some aspects resonate with your own lived reality. But this is not about me. This is about all of us, and this is about our story, and recognizing that the global pandemic has affected all of us, some in very similar ways and some very different. Where there have been a lot of lessons to be learned, I don't think we can focus on the positive lessons before we give space and recognize what has been lost. Those of us in healthcare have witnessed extraordinary loss, and while many have been impacted by the loss of a friend, a loved one, job, or just time with others. So I'm going to ask that we take a moment to close our eyes and reflect on the losses that we bore witness to over the course of the pandemic. So please close your eyes with me for just 10 seconds in a moment of silent reflection. So after acknowledging the loss and having sustained so many injuries, the message is we are still here and we are still moving forward together. Now I want to shift our focus to what we have learned. Despite all the challenges that we have faced, we are growing, and there is plenty that we can learn and take from this. There are many lessons still to be learned, but we are moving forward and we can shape how we provide CF care in this moment and for the years to come. How do I know that CF care is improving? Well, Dr. Boyle mentioned earlier, there are many positive outcomes in CF, including a significant increase in the number of pregnancies in women with CF. This suggests to me not only better health, but potentially a brighter long-term outlook. We also saw a decrease in the need for lung transplants. And most importantly, over the past several years, survival rates in CF have been getting better, and we continue to see that upward trend improving. While not the only influence, increasing access to highly effective modulator therapies are a very large part, and I encourage you to learn more about this impact in the upcoming plenary delivered by my colleague and my mentor, Dr. Manu Jain. At the same time, when outcomes are improving, we are seeing a change in how care is delivered. So how is care delivery changing? For those of us in the clinical realm, we have all seen and felt this change firsthand. But what does the data look like? Looking at the graph in the blue, you can see that in the pre-pandemic era, most of our visits were in person with very few non-clinical visits. However, that rapidly changed in March of 2020 with a significant increase in the amount of non-clinic visits or potentially telehealth visits and a decrease in in-person visits. And this has continued to evolve and change. And still we have an increase in non-clinic visits compared to the pre-pandemic levels. And this data demonstrates how rapidly changed the way we provide care and respond to the pandemic. This data demonstrates how we rapidly changed the way we provided care during the pandemic This data demonstrates how we rapidly changed the way we provided care in response to the pandemic as the catalyst for change, and that is persisting. So just like with COVID-19 and CF, we find ourselves in a rapidly changing and evolving world. With improving health and global outcomes for many patients while simultaneously delivering new ways, we are facing a new world. This new world is exciting in many aspects, but we have all felt how hard change can be sometimes. We can look at the rapid changes since the start of the pandemic for some guidance and grow from those lessons learned to date. So facing the COVID-19 pandemic provided some clarity into how best we can tackle a condition that is new to us while providing care in vastly different ways. The three main lessons for me during COVID-19 were that were relevant to our changing CF landscape include the following areas. The first is agility with innovation, so spotlighting the lessons learned with telehealth. Second is the importance of communication within relationships and ways to strengthen our skills. And finally, we'll end with thoughts about planning for a sustainable future. Changes call for innovation, and innovation leads to progress. There's been a lot of innovation in the last few years, but perhaps the most revolutionary has revolved around the incorporation of telehealth and remote monitoring. As we approach these lessons, I want us to think about them in the setting of questions, questions that we have already asked, and we'll provide some data, but hopefully it will spark your own ideas, questions, and innovations, and we'll consider additional questions that are still yet to be answered. So the first question we'll look at is how quickly did CF programs adopt telehealth early in the COVID-19 pandemic? So survey data in the spring of 2020 showed that 97% of programs developed some method for telehealth within their program or center. A deeper dive showed that approximately half of the visits were in person, and others consisted of computer with video as well as phone. So the lesson learned here is that CF programs can adopt telehealth rapidly and adapted it by using multiple means to address patient needs. So that leads us to the question of how do care teams and patients feel about telehealth compared to in-person care? To shed some light on this, survey data showed that most CF care teams reported they were able to provide the same level of care using telehealth. And when patients and families were asked, about half of patients also felt that they received similar care through telehealth. However, it's also pretty clear that approximately the other half had a relatively negative view of telehealth compared to in-person care. So we must recognize that there are pluses and minuses to this approach to care and tailor it for its best use. But was telehealth easy for people to use? And the answer here was also a resounding yes, with 9 out of 10 participants reporting that telehealth was easy for them to use. What about when it wasn't easy for them to use? What were the barriers? And not surprising to most clinicians, the main barriers were related to sound or video quality, poor internet connections, or issues with the platforms itself. And again, these are patient-reported issues, but are things that we have seen at the front lines ourselves. But while annoying, they're also potentially something we can overcome with time, training, and some additional infrastructure. So is telehealth universal? Are there differences in how telehealth was delivered and perceived in different patient populations? The answer here is also yes. Preliminary data shows that there were identifiable barriers between different racial and ethnic groups within CF programs. If differences were found within ethnic groups, we can also consider other subsets. And this would include age, symptom severity, or potentially location of CF center, just to give a few examples. So telehealth is not a one-size-fits-all approach, and we should consider multiple variables and needs. And finally, is there a role for telehealth and remote monitoring in the future? So most clinicians, both pediatric and adults, felt that there was an ongoing role for telehealth in at least some visits in the future. To build on that, when patients were asked about remote monitoring in the future, over 90% of both pediatric and adult patients reported an interest in the use of home spirometers. So this is something that we should look at to take with us in the future. And what we have learned is that telehealth has been rapidly adopted by almost all programs, but there's pros and cons that exist. With the overwhelming majority of patients and clinicians feeling that there's an ongoing role for this clear, we need to learn about how telehealth is best used, as well as its limitations. So the benefits of telehealth are in the flexibility and timing. Then less need for transportation. It also facilitates shorter, more frequent contacts. And we can use it at different times outside of our normal clinic schedules to help facilitate patient interactions. There's also a greater focusing on listening to the needs of patients rather than reverting to our traditional exams and our old routines. It also offers the capacity for in-home education. We don't need to bring patients back, and we can observe them doing their treatments in their own home with their own equipment at their own time. However, telehealth is not an ideal format for every encounter. telehealth can certainly pose challenges for visits with young children, especially when needing to observe and have them participate in the virtual setting. And it's not well suited for sensitive topics. So we lose that human interaction. And so having our more sensitive topics through telehealth is not the best use of this technology. Also limited in terms of evaluating family dynamics. So given the singular focus of the video onto one person, we're not able to really have the more expansive and larger group analysis required in many of our visits. And finally, there's the ongoing infrastructure and access issues, and we'll address more that can be addressed for a more seamless process. And these are the questions that we've only begun to investigate, and really it's a great place to start. But what about the real world? What about those providing care? How do they meet the challenges in the moment in real time? I'd like to introduce you to Rhonda List from the University of Virginia CF program in Charlottesville. Rhonda is a member of both the adult and pediatric CF teams at UVA, as well as a mother of an adult with CF. She is going to share the UVA adult team's experience from the trenches and work in telehealth.
Reflecting back over the time since March 2020, it is astonishing to realize how much we have done and learned together in conditions of uncertainty, rapid change, and fear. For our team, the shutdown of outpatient clinics brought new determination and cohesiveness, and it really highlighted the strengths of every single team member. From the start, the question was always, how are we going to maintain our standard of CF care through telehealth? It was never, ever a question of if. And with that mindset, and by leaning into our QI skills and culture, we held emergency meetings, and the 9 of us just brainstormed. Martina had a WebEx license and experience with home spirometers. Lucy and I discovered that our clinic tracking sheet could be converted into a Google Sheet for real-time and synchronous editing. And Dana found a HIPAA texting app for communicating real-time clinic movement and relaying patient information safely while we were all in different places. Heather discovered screen sharing, which could work for mental health screeners and so much more. It was like that story about stone soup, where everyone brought something that they had and they threw it in the pot. And one step at a time, we mapped, tested, learned, and scaled our way forward. So yeah, I would say our team, our community, has learned and achieved a lot during the pandemic. We have been privileged to be recognized to share those things through multiple manuscripts, presentations, and posters. But what you probably won't hear or read about from anyone are the costs and the tolls that are paid along the way. It was frustrating to spend precious time, effort, bandwidth on things that yielded very little success. Our drive-through sputum drop-off and home spirometer pickups, for example, or about the sweat and tears that went into learning how to convert the data from a variety of home spirometry devices into a standard format that could be compared to the baseline values that were established on clinic spirometry equipment. Yeah, that was as intense as it sounds. And our respiratory therapist, poor Martina, she never threw up her hands. She just kept finding another way to do it. We also learned lessons about the importance of cross-training and good process documentation, because we were called on a lot to expand our roles and fill intermittent gaps in our care team. We transitioned a social worker, 2 clinic nurses, and 2 dietitians on our core team in the last year and a half, all while in the midst of transforming nearly every core process of our CF clinic model, at least once. But despite the horror of the pandemic and all of the logistical challenges, there have been a lot of silver linings. More connectedness with our CF program peers through accelerated learning and sharing. Even greater partnerships with our patients and families. We ask more than ever of them to collect their own health data, figure out multiple new technologies, and forgive our sometimes clumsy executions or interruptions from pets or family members, and to provide us with feedback every step of the way. But in our shared vulnerability and that mutual reliance, I feel we all became so much more human to each other. And through it all, we have been keenly aware and deeply grateful for each other's expertise, skills, and ideas. None of us could have done this alone. And I believe that what we have learned together over the past year and a half has made us more agile, better listeners, stronger partners, and ultimately better equipped to respond with confidence to the needs of our community, no matter what the future might hold.
Thank you, Rhonda, for sharing with us what your team was able to go through to find solutions to meet the needs for our patients. And importantly, highlighting some of the importance of communication. With that, my quote for you is, communication leads to community. That is, to understanding, intimacy, and mutual valuing. So now we're going to switch gears and talk about communication within relationships. So just as Rhonda had mentioned, there's several elements of communication that I'd like to highlight here today. The first is relationships and trust are the keys to communication. We saw that in our video. Relationships are so important, and communication are the key. The next we also heard about was the importance of connecting to new ways during this pandemic. And finally, as we are connecting in new ways, we're looking at building a team-based approach specific to CF. So what can we do to foster connections during this challenging time? So we learned through this pandemic that information was critical and that sharing our information was possible through many new and innovative ways. These included town halls that were held by CF communities through national, local chapters, as well as centers themselves. These were formal as well as informal venues, were quite helpful during this process, and as there was a lot of new information to be shared. We could also connect by focusing on not on just our shared humanity, empathizing even when there was no solution, with a supportive ear, as we saw from many of our colleagues on the front lines. And I can't emphasize enough the value of shorter check-ins to help supplement understanding in a rapidly changing world. How many times did we just check in to help you alert you to new needs or concerns? We benefited so much just by checking with our teams and patients, as the needs were constantly changing. And our patients also checked in with us, their healthcare team, which for me was one of the high points of a very difficult time. Most of us were not traveling during this pandemic, but it's important for us to just check in and be present. It was a large component of connection. All right, what can we do to make communication more effective? So assessing patients' concerns allows clinicians to efficiently obtain information while strengthening relationships. In essence, this is how the work gets done. So we as clinicians need to get to the heart of what our patients' concerns are, and we need to do it efficiently and effectively. When we're able to do that, we can both build relationships and do our jobs. An approach that is being developed is investing in CF-specific team-based training, like the Partnership Enhancement Program, or PEP. This is a communication skills program consisting of workshops to better build skills within CF teams. Most importantly, this program was built by CF clinicians for CF clinicians. The goal is to provide skills and strengthen those relationships. And over 20 programs have participated to date, with programs reporting a high degree of satisfaction. But Michelle, I haven't had a PEP workshop yet, and patients are getting information in so many sources these days. It's hard to know their thoughts. So what are some of the communication tools we can use to gauge patients' concerns? When we're discussing ideas with patients, the efficient way to get to the heart of their concerns is to ask. I know it's revolutionary, but we want to know and get their thoughts on a topic. There are so many sources of information, and it really helps us to frame how they're understanding with communication by getting their viewpoint and really just asking. It doesn't matter where these ideas are coming from. In reality, the reality is it's sparked a concern, and we need to directly address it before we move on. So the first step is to ask. So we're going to ask an open-ended question in a non-judgmental fashion. If we want to know their thoughts on COVID-19, we're going to ask, What have you heard about COVID-19? And then we're going to wait for them to tell their thoughts, which will focus us on where they're coming from. Is this a general question or a highly specific concern? When that's done, we're going to respond with a positive. That's a really great start. And then immediately thereafter, we're going to tell them our thoughts based on the information we provided. For example, let me add to that. The key to understand their thoughts and to build on their pre-existing information structure is really meeting them where they're at. So again, asking an open-ended question, responding with a positive, and then telling that extra bit of information that is digestible will spur continuous dialogue and build trust. Remember that the goal is not to change their viewpoint right then and there, but to open the idea and build trust for further discussion. So what can I practice today? When you're in your clinic after NACFC, here are some quick tips to improve communication. The first is be yourself and speak in your authentic voice. Patients trust you when they feel that they know you. So don't be afraid to be yourself. Also understanding that clinical encounters are stressful for both patients and providers. So always add some small talk before you advance into the big talk. Get to know them, how their day is going, before we go into the work that we're trying to do. It will make the encounter so much more enjoyable for all involved. And then we want to address patients' concerns early and completely. So ask them, what issues or concerns would you like to discuss today? Make a list, and after each item, ask what else until that list is complete. It will really help you to focus on what patients' concerns are, as well as able to share what your agenda items are. And I will assure you, having done this for a while, there will be time, and you will have so much more of an enjoyable encounter knowing that you did what patients are needing. And then we're going to ask open-ended questions and always listen before we speak. Allow patients to tell their story, give them time and space, understand where they're coming from before we offer our advice, our feedback. And after they've shared their story, we're going to respond with empathy. We don't always need to have a solution. We can just offer support, and many times that's enough. There's been so many lessons to communication. I hope this highlights some of the potential methods to approach conversations while strengthening our relationships with patients and your teams. And so now we're going to switch gears and talk about the future. Yes, the future. So the best way to predict the future is to create it. For our final section, we will talk about planning for a sustainable future in CF. When we plan for a sustainable future, there's two aspects that I'm going to discuss with you here today. The first is focusing on equity in CF care. And that's really concentrating more attention and resources on those with more severe disease or those still awaiting highly effective modulators. And then secondly, we'll discuss the role of the CF care team, which may be evolving. As people with CF are leading healthier lives, potentially without as many admissions or interventions, we may need to adjust our care model and also consider the inclusive role of CF experts in this evolution. So let's take a minute to talk about the difference between equality and equity. So if the goal is for everyone to enjoy watching the game, you can see that equal distribution of a similar resource does not always meet the goal for everyone. That's equality. In order for everyone to enjoy the game, we need to look at equity. Again, if your goal is for everyone to be able to enjoy the game, that means some need more and others may actually means thinking outside the box and developing something completely different. As we think about resources, understanding the difference between equity and equality is going to be important. We all want to be able to cheer on our CF teammates. So we have been hearing a lot about equity these days. Is equity new in CF care? And I would argue that achieving equity has always been the goal of the CF community. The CF Foundation was started on the premise of all people with CF living the highest quality of life. It has always been an inclusive community that is trying to get everyone to the finish line, everyone to be able to watch the game. So as therapies are developed, we do not withhold them from those who are eligible, but we work to expand the coverage. We work to expand the coverage and the opportunities for all our patients. But we know that inequities still exist, so it means looking at new ways to reach all patients. And I encourage you to learn more about this in Plenary number 2, entitled Working Together to Pave the Path to a Cure, where we'll hear about some of the new and innovative approaches to find cutting-edge therapies for all patients with CF. As we think about equity in CF care, we need to adjust and recalibrate our clinical efforts to support greater health equity. This means acknowledging the impact of factors, including highly effective modulator treatments and their potential long-term impact on patient outcomes. This is a complicated topic, so I will admittedly provide an oversimplified and hypothetical example to demonstrate this concept. I also want us to broaden our view of CF success beyond FEV1, as we know patients are seeing a wider variety of symptoms that affect their lives. So to prevent us from reverting to our typical FEV1 over time and further embrace the hypothetical, I'm going to reframe my axis for you today. So here we will depict the y-axis with symptom severity, and we'll depict it with some smiley faces. And so we have happy faces at the bottom in green, going up to more severe symptoms with frowny faces in the red on the top. And also I'll depict axis of age with pictures of me across the years and over different generations to really show representation of advancing time. And I'd like you all to please note that as a teen, preteen of the 80s and 90s, it was very difficult for me to find an acceptable photo for me to share with you today. But with that said, now that we've reframed our thinking to think about hypothetical symptoms of severity over time, let's think about 3 potential scenarios and their care needs. So the first I've depicted in a blue line. This represents patients that are still awaiting highly effective modulator therapies. So symptoms we'd see here would start out low, but continue to increase with advancing age. Now let's consider someone who has started on highly effective modulator therapies as a young adult. In this instance, we may see an improvement in symptoms after starting a modulator, with a relative plateau at a lower level than we saw prior to starting the modulator, as depicted in our yellow line. And then finally, I want to imagine if we were to initiate these same highly effective therapies, highly effective modulators at a much younger age. We may see a relatively lower overall symptom severity compared to that same patient for whom the effective modulator was started at a later age or does not yet exist. I think we can all agree that the lifetime severity of symptoms would be different if a highly effective modulator was started in the little girl with the bangs on the left compared to starting it in that same girl in the middle versus not starting a modulator at all. And the differences in groups would only increase over time. So my point is that while heterogeneity of symptoms has always been present in CF, with increasingly expansive use of highly effective modulators initiated at different times and ages, these differences may continue to widen. This puts into light the need for even greater consideration of equity in our delivery of CF healthcare moving forward. Some will need more resources, and fortunately, some may need less, and that's a very good thing. Finding that balance to achieve the goal of highest quality of care for everyone with CF is a challenge that we will face increasingly over time, and I know that we're all up for it. Okay, so what may better equity in healthcare look like? This may mean a greater focus on resources to those with highest needs. We all know there are vulnerable patients, populations within our own clinics, and that changes over time. Programs are always flexing to provide care to our highest risk patients and better achieve equity and outcomes. And we need to continue to do so at a much higher pace. We also need to make more deliberate steps to empower our patients for greater self-management. There has been a long history of educating and training CF patients toward greater self-care and monitoring. So we can build on this foundation, and patients are ready for it. And they're ready to increase their participation in care. And we are eager to make a more collaborative role in self-management, including remote management of their PFTs, weight, and symptoms. We need to encourage interested patients to take on this more independent role with the guidance and support of their care team. And finally, this may mean reimagining CF guidelines. As people with CF are eligible for highly effective modulators, we need to reconsider reshaping guidelines to better align care needs and treatment options. We are already looking at what treatments are needed to maintain the highest quality of health in several withdrawal studies. With increasing variability of symptoms and needs, it's clear that a one-size-fits-all approach to CF needs to be re-explored, and the future is now. We as a community need to continue to work together with our patients to determine optimal needs for long-term health supported by data, innovation, communication, and resources. Again, our goal is to have everyone be able to enjoy the game of life, and it may mean that we need to reshape how we look at providing care. In this context, let's consider what resources are involved. Typically, when we talk about resources, we think about space and materials. This could include things such as clinic offices and space, telehealth equipment, spirometry and labs, material resources, etc. But there's also a large volume of resources within data and informatics. And our registry data is a wonderful resource for patient data. In addition to what we have in patient reporting, EHR capabilities, there is a lot of data to help shape us as resources. And finally, there's people power, our most valuable and limited resources. This is the clinical staff or FTE or percent efforts, the people that are doing the administrative work and support needs, as well as the expert time, including our consultants, researchers, and most importantly, our patients and families, as well as others that have yet to be defined. It is the people power that's the most important and precious resource in healthcare. But let's first talk a bit about the data. So how do we harness data to better meet patients' needs? First, we want to improve transparency and accessibility. And this is already in the process, but we can do better. We've seen open notes as well as open access to publications, and that's just the beginning really in terms of transparency and accessibility. There's also the ability to harness data through dashboards and other measures that we can use to collate, identify, and adjust to new trends. These can be disease-specific on comorbidities like CFRD, or response to meds, or can be setting-specific such as admissions. As an example, when COVID-19 first struck, we recognized some factors that were predictive of potential respiratory failure and the need for early ICU transfer. So within a few days, our IT department developed a patient dashboard with all hospitalized COVID positive patients and listed the important monitoring and prognostic variables. This list was color-coded based on what we determined a decompensation factor that we designed based on some important metrics that we noted at the bedside. And this dashboard made it easy to identify our highest risk patients and give them extra attention if needed. This is just one example of how we can use existing infrastructure to monitor populations and intervene early to help achieve better outcomes and utilize resources. But healthcare is not all about data. It's the people that make it work. In terms of people power, let's consider how the role of a CF care team might be changing. And the reality is the adult CF population is growing. And as people with CF are living longer, there is going to be an increase in the adult population. With longer CF life expectancy, there are not only more people, but we also expect new health challenges that we may not be familiar with yet. In addition, the role of the CF care team may be evolving. As many people with CF are attaining healthier lives, we may not be requiring as many admissions or inpatient interventions. People with CF will always need inpatient care. However, the volumes may be shifting towards the outpatient setting. We do not want to lose the expertise of our inpatient providers, but we may need to reimagine how teams are structured or the work is performed. This could look like a shift in consultation service or a hybrid model of care for inpatient or outpatient care. The goal is to keep the highest quality of care for all individuals while retaining the expertise of our current teams. So we may want to think about how best to restructure and organize work in a changing CF landscape. So how is the CF care team evolving? The answer is we have already evolved and continue to do so to meet the new needs of our patients. I think of the CF care teams very much like a sports team. So we all have the same mission, but our role in the game may be very different. So I will pose to you 3 distinct groups. The first, I'll term the traditional CF care team, or as my kids might call them, the OG CF team. This typically consists of pulmonologists, nurses, dietitians, respiratory therapists, social workers, clinic coordinators, pharmacists, and physical therapists. And then we have the extended CF team with our primary care physicians that we brought in and our research coordinators specific to CF, as well as endocrinologists, gastroenterologists, and psychiatrists, and our lung transplant teams. And then finally, there's our expanded CF care teams, or the special teams players, if you will. These are going to be our urologists, reproductive endocrinologists, and fertility specialists, obstetricians, cardiologists, geriatricians, as well as some specialists that we still haven't figured out that we need yet. This expanding team is necessary to build upon our existing teams to meet the needs of the changing CF population. So you may be asking yourself, so what does the future of CF look like? Well, it's going to look like a lot like it already looks now. The spaces and materials we use will change some, but at the core, you're going to see a patient and provider sharing ideas and connecting in a shared space. So what about data? We already are using data, and you can see 2 examples of ways to access it with computers and smartphones. There are so many aspects of data to harness, but at the basic core levels, we already have ways to access it. And then finally, it's the people. And we may be expanding to new specialists, but the foundation of our care is within the patient-clinician relationship, and it's linked with communication and trust. So as you can see, the future is very similar to how it is now. However, we may be adjusting some elements to better meet the needs of a changing landscape. So we have faced many challenges in the last few years, and we will certainly face more in the time ahead of us. It seems like a very uncharted path before us, which may make us feel uneasy. But know that there are many lessons that have already been learned and many more questions that we can successfully answer together. The COVID-19 pandemic has not been easy, but it has shown us the capacity, resiliency, and commitment of our teams to each other and to our patients. We have made incredible advances in the midst of extremely difficult circumstances and started toward a better and brighter path with new tools to help us along the way. Let's embrace the lessons, sparking more questions that we can successfully answer together, utilizing a dedicated, diverse, and growing team of experts to guide the way. So as we set out on this conference, I'm going to leave you with 3 final questions to frame your learning. The first is, what do you bring to the table? So just like Napoleon Dynamite, we all have skills. Please don't underestimate yours. The second is, what can you learn from this moment? Think of your own story of perseverance and resiliency. How can you use that to make the world better? And then finally, how can you bring everyone along with you? We are all one community with diversity that only makes us stronger. We need to look forward with equity and inclusion as we continue to meet these moments and all the moments to come moving forward together.